Okay, it's time. So, welcome for those who are here. And like I said, we will record this session and we'll continue to allow people to log in as they can. This is really more like I will say, a casual conversation about what happened with our thread in Gaggle regarding the needs to know more about what people are doing in Epic regarding documentation. And then I was able to reach out to our guru and this topic, my very good friend and colleague, Megan, who has been working with Epic for years in FQHC in Madison, Wisconsin. And together with myself, because I work on the same site as well, we have just been part of the evolution of how the nodes have evolved through the years. And we're just here really to share what we have done and it has helped, and who to bring in the conversation when you're dealing with this type of questions that you're asking yourself, what has been helpful that we have done, but also we want to just continue to reiterate that what we're providing are just tips and tricks, but then that depending on the state that you are or your side, things might look a little bit different. But hopefully with everybody's participation, everyone will get valuable information. This is not to be a presentation at all. We will actually don't have slides. We will share our template that we share on the thread, that it's helpful, but more than that is just, hear about what are your questions and, together come and learn all together about this. So thank you, Megan, for joining. So I'll give the word to you while I'll put again the template for those who are just joining. Perfect. And we'll go from there.
Thank you, Martha. I feel very happy to be here. Martha's setting me up to sound like the most amazing expert ever. So thank you for that. Apologies if in the background you can hear any loud noises. I'm in Madison, Wisconsin. We're having our monthly drill, our practice for the tornado sirens. So it
does, yeah.
have them go off at 12 o'clock on the first Monday of the month. So sorry about that, if you can hear it. Go Madison, indeed. So I've been at the FQHC, as Martha said, here in Madison at Access for now 16 years, and we've used Epic that whole time. We're lucky enough to have it as a part of our affiliation with UW-Madison. So we have full Epic. We don't have Ocean Epic. That's the version that we have. And we've done a lot of different things over the years with templates. I think early on, we realized that having one template that the whole team uses is very helpful in making the notes more cohesive and making them comparable and easy to read. We started with a classic SOAP note template. And I think in regards to the chat comment that just came up in terms of Ocean versus regular Epic, I think a lot of the template-y kind of things should translate pretty well. It's just what library of smart phrases you have access to. I don't know, it may be different. That's not something I'm familiar with, but you can certainly search in the smart phrases that exist in Epic to see what's already there. So we started with a SOAP note template originally, and then we kind of modified it as needs dictated over the years. New team members would have ideas. Our coding and compliance people spoke to us several times and indicated different details that needed to be included for different kinds of notes. We eventually switched our note order to be APSO with assessment and plan first and subjective and objective later. That was matching what our physicians and medical providers were doing in clinic, as well as putting the information that they wanted to read first. So that's why we switched the order. But we've kind of done more over the years as Epic had more availability for customization. When I first started, you couldn't customize dropdowns, for example. You could only use dropdowns that they already had in existence, which was fairly limiting. Now you can make whatever you want. So we've done a lot of different things with dropdowns. So I think the biggest thing to think about is what are the needs for your system? What are the things that are going to be helpful for you and that you might be struggling with? Making sure to talk to your coding and compliance people with whatever you get set up to make sure that they say it covers what it needs to cover. That's a really helpful thing to do periodically as well. We've done a few modifications over the years. One of the things that we've added more recently into our subjective is a whole kind of list of questions for adult ADHD that we've put in there as a way to help. We had, as I'm sure all of you have had, an influx of desire from patients for screening for ADHD as adults. And in order to facilitate that, we just created something that you could insert into the subjective if you wanted to, as another flow of things to go through. And you can leave it in there or not, kind of up to the clinician's prerogative. But it made it helpful for people to get through those visits. So things like that, I think, are possible to do as well. We've talked about doing a separate template or like additional pieces to the template for PEDS visits. So far, we haven't really felt the need for that, but that is definitely something that we've talked about as well.
I
So
think
those
one
are
of the one
yeah,
of
go
the
ahead,
other
Meghan.
one that came in that I'm thinking about, Megan, it's our telemed template. But
Yes.
one of the things that we started with was we had like a regular template, and then we have our telemed template. What we're trying to do, and correct me if I'm wrong, Megan, is actually just to have one template that you can select the drop down that you need,
Yep.
and that template will kind of be a telemed or a regular visit, but instead of having multiple templates.
Mhm.
So again, on Epic, that's a functionality that you can do in which you create those drop downs, and then the template will accommodate to whatever you're doing. If it's a telemed, a regular one, or a ADHD, we need it,
Right.
versus having 7 different templates, right? So, but again, that has come with time and playing with it. One of the things I will highlight is that if you're working on a team, it's important to bring these ideas to the team because you get really good input, right? If you're working solo, still try to match what your providers are doing. A lot of the times your answers will be on what other team members of the clinic are doing. And again, just sharing what we have done here at Access.
Yeah, I appreciate the comments there, Martha, because you're right that having the drop down to differentiate whether it's a virtual or in-person visit is really helpful. Then you don't have to remember different templates that you're using for different types of visits. You just use the same one. And the same for our students. We have the same template for them. They just have additional drop downs that they throw in that'll plug in the fact that they're a trainee and a student being supervised. So that's really helpful as well. I see a question in the chat about the ADHD questions. If they're in a quick text, they're just a part of the note itself. So they're not anything that you can pull later. And that's a really good question because that's another huge piece to consider in terms of how you're formatting your note template. There's different things in Epic. You can create smart data elements and things like that, and different things that can tie into pullable data later versus just having the text of your note that's not pullable really in any way later on. So those are really important considerations as well to talk to your local IT people to see what they're able to do, your local Epic contacts and your coding compliance again to see what they're able to do. So that's the way that we've done that. We've also helped to create a few smart phrases that we've offered to our providers that they can throw into their template. So that's another option as well if there's things that we're trying to prompt providers to do as well.
So make like
Yeah,
let me just like if someone is starting with Epic and they feel they want to create these drop downs, who do you think would be good to have in their clinic team to start with this? I mean, you mentioned that we have communication with IT, probably leadership, let's say medical directors or the BHC director, but who will be the people to be involved when you're creating or moving to an Epic system?
Yeah, it's a good question. I think, as you said, some kind of leader having that involvement, somebody from whoever your IT or Epic contact person is. So on that side, if there's some kind of super user, that's often a phrase that's used for Epic of somebody that really knows exactly what they're doing and they know all the tools and tricks. Getting somebody like that involved can be really helpful because one of the things that I've encountered many times over the years with Epic is that there's tools there that I didn't even know were there because I didn't think to ask, right? Because I didn't even know it was a possibility. So why would I ask for something that I didn't even know was a thing? So having people there that have tons of training and background in Epic can be really helpful. You can talk about what you want to have things do, and then you can have them say, what can we do to make this more efficient? And they can help you out with it as well. So that can be a really useful piece too. One of the other things we've done in terms of screeners, we enter screeners in a different place in the chart so that they're pullable later, but we did create smart phrases, like a whole list, a drop-down list of whatever screener we've used so that we can blow the results into the text of our note for easy reference for providers and for people reading the note later. So there's things like that that you can do as well to make things a little bit easier and not have to double your work in terms of typing everything in a couple of different times. Patient instructions is the other part that we've made good use of when you're writing an epic for things you want to give to the patient that they can take with them in their after visit summary. There's a section called patient instructions that you can type. We'll do that collaboratively with patients a lot. And there's a way to a smart, like a way to have it blown in to the text of your note, patient instructions, basically, and it copies and pastes it right in there for you, which is really cool because then you don't have to type out your plan twice and it's just there and it's done. So that's a useful one to keep in mind too. So the super users can be helpful as well as having people on your team if you're getting into Epic and wanting to know who should be involved with getting that started. People on your team should be there too in the behavioral health team so that you have some representation there. And then maybe even a provider representative, right? For like, what are they looking for in the note? What do they want to see? What's going to be easier for them to read? That can be helpful too.
So I'm getting, if you cannot open the note template that I am posting on the chat, please send an email to Hannah and she will gladly email you that template. Now, I want to highlight that this is a Word document that we created for a Documentation Palooza event because we cannot show you the electronic medical record, or in this case, Epic. What I did was actually, it's a Word document who has the drop downs or an idea of how that will look like. Now, it's very extensive because, like, for example, in intervention, you see a list of type of interventions. This in Epic looks differently because you click and then you just select, and then the interventions that you use are the only ones that will actually appear. Thank you so much for sharing that. It's just, again, this is just an idea of how you can start creating a template. One of the things that you want to keep in mind is that the helpful issues to have a template is that it would you will make your note very uniform. So if you have different people in your team, they will use the same template, and that is easy when you're reviewing a chart, or for just documentation purposes. You're gonna make your team work in a very uniform way versus each of them having different templates and styles of documenting their note, right? Again, this is just an idea, but it's more important that you connect, like Meghan said, with your IT people and create those drop downs or those smart phrases that are helpful to have.
Yeah, so just to quickly go through this document, this Word document, there's a Word document representation of the Epic Smart Phrase. The assessment part, this is often what it looks like. You can have as much in here as you want in terms of pre-formatting it. You can put in the 3 stars that helps you to just jump through it within Epic. If you press F2, it just jumps through. Your intervention type, all of these checkboxes here, this is a drop-down list for us. So you just click it once and then you click the ones you want and it goes in. The plan section as well, we have kind of a basic format. There's not a lot to it because we're leaving space for you to put in what you want. And this is where we also have the link set in the first one here to blow things in directly from patient instructions. So if you've already typed it there, it'll just blow it in automatically here, which makes it really easy to format as well. The subjective part, this is the section where we have put in a couple of extra smart phrases right at the beginning in terms of the consent, to be able to have the different consent for telemed or video visits versus in person. So you just pick what type of visit you had, and then it'll blow in what the coders have said you need to have included, right, for that part. And for us locally, our coders want us to confirm, for example, that they're in the state of Wisconsin. So that's in there as a prompt to be able to confirm that. And then you have your open part for the subjective. This part that's usually just an open text part here where you can just type in whatever you want for your subjective is also where we've added an extra smart phrase, for example, for the adult ADHD questions, to be able to guide people through if that's something they want to do. That was a relatively new thing that the team had come up with and said that would really be helpful given how many patients were having coming in asking for this service, and they want to know more about whether they have ADHD. And it's a pretty mixed bag in terms of what people are coming in with in terms of any historical documents. Then in terms of the duration of the problem severity, again, that was something our coders wanted us to have, so we threw that in there. Fine, makes them happy, great. Objective section, these are all drop downs as well, so the checkbox is here, but within Epic they look more like a drop down, and we've done different things to that over the years as well to make it easier to read. And then the section here in terms of the screeners, again, drop downs to be able to link them in.
Can you click Meghan in any select so they see?
Yes. Aha, so you can see the
the different
The choices.
options. Yeah.
Yep, perfect.
Yeah. So again, once you open this Word document, it's just an idea of how you can share this with your IT people so they can create a drop down and, you know, things that are useful for your note documentation. And another thing that it's beneficial, like Meghan has mentioned, is that, you know, we want to be effective with time, right? So if we wrote the patient instructions or the AVS and we create a dot phrase when we are writing already the note, those are seconds that you just click, you know, smart phrase, and then those those patient instructions will blow in directly to your note versus you writing the patient instructions again. So again, it creates consistency in your note. It's time efficiency for you versus doing things duplicated, but also for data collection, right? If you want to start collecting, you know, different diagnoses or ages or whatever, that's something that it's helpful. I don't know, Meghan, if you want to talk a little bit of how we use the data with our notes.
Yeah, before I do that, I want to give a huge shout out to my team member, Alex Smith. He's our local Epic guru on my team. He's created a ton of these drop downs very patiently, listening to everybody on the team and putting together what we're asking for, and then redoing it when we all change our minds and decide we want it to look a little bit different. So he's been an outstanding resource, which is another thing to keep in mind. If you have somebody on your team or within your organization that just kind of gravitates towards this stuff and gets it and likes it and they're kind of into it, maybe that's something you can grow and develop, right? And utilize with benefit, because you're going to have otherwise people like me that are like, I'll use what I have to and I'll learn over time, but it's not going to be the thing that I'm going to jump into and figure it all out along the way. So sorry, Martha, that was a little sidebar.
No, but I'm glad you gave a shout out because it is true. I mean, there's sometimes those good resources that we have in-house that we don't even know, so use them.
Yes, no, it's great. It's great. So in terms of how do we use the data, I think it's a big thing to talk to both sides of the coin. So if you have any internal data people versus people on the Epic side, there's different reports that can be pulled through billing data. That's one side of data that is automatically gathered for billing departments. So that might be one source where you talk to people, but that is limited, right, in terms of what's in there. So if you're looking at anything beyond that, that's where you're going to want to talk to your Epic people as well to see how do we record that. What do we need a smart data element? Is there another place where we can put data to be able to have it be automatically pulled? The things you just type into your note typically are not going to be things that can be pulled later unless it's created with, again, that smart data element, or you're entering it into a flow sheet or a different section of the chart where questionnaires typically go, and then it can get pulled more easily later. So it's really kind of thinking about what is it that you're hoping to get, what are your needs, and then trying to figure out who can help you to get those met is going to be a big part of it. And as much as you can, thinking about it on the front end can be helpful. I know a lot of times we don't think of that until later. They're like, oh, it would be nice if we could get this data. You know, that would be cool too. I know some organizations in their medical records have the ability to mark off whether a visit is a first-time visit for BHC, for example, or a warm handoff or those kind of things. Right now in Epic, we don't have a discrete field for that that's pullable. That's something that we're working with our data department on to see if they can come up with some kind of clever algorithm to help pull that, but that's still in process for us right now. So right now, if I'm looking at that kind of data, I have to pull it by hand, which is time intensive as well.
I think another thing, and correct me if I'm wrong, again, that productivity, like how many patients were seen by BHC or which providers, right?
Yep, that kind of stuff you can easily get through billing data very easily, because the billing data reports that we get typically have diagnosis, date seen, who saw them, that kind of stuff. And so, and age and gender, like demographics and all that. So you can easily sort it out that way. And then you can compare who you're seeing for BHC versus medical providers pretty easily with that kind of data too. So you can get quite a lot with the billing reports that your billing people might already be pulling. So that's always a good thing to check in with those people. Yes, I see a question, Stacy, go ahead. Well, feel free to jump in, Stacy, if there's something that comes up.
There's more at the chat. We can start with those.
Yes.
So Robert is asking if the drop downs in the document modality in action appropriate for billing coders.
That's a good question. The intervention type has been something that was asked for from coders. So yes, it follows for that. In terms of billing, I think sometimes it fits and sometimes it doesn't. If you're using health and behavior codes, they did ask for a little bit of other phrasing for that. So that's something to check in on in particular. Otherwise, if we're using our typical psychotherapy codes, it'll be fine for that. So the health and behavior codes, I have heard different answers from different coding people in different states. Yay. So check locally and see what their requirements are for that. Are there some jargon and acronyms that you're avoiding with more patients? Yeah, that's a great question. I appreciate that, Phil. In terms of our template, we have tried to not have the template have a ton of jargon. We've tried to have it have more plain words and not have any abbreviations, right? Having everything spelled out, which is a very cool tool in Epic, FYI. There's a dictionary or thesaurus, or I think it's called a thesaurus in there. There's a tool in there where you can put in the common acronyms that you use, and then it'll spit out what the full thing is in your note. So you just type in your little 2, 3, 4 letters and it'll throw out the whole thing. So like CBT, I did as one, or GAD, I did as one, and then it throws out cognitive behavioral therapy or generalized anxiety disorder. And that is a super awesome tool. It's great. And I always, unfortunately, forget how to go back into it. So I have to find my good friends in clinic that can help me get to it. So that's a great one to update.
Philip is saying it's called Dictionaries Autocorrect.
Dictionaries, thank you.
I have no idea how similar Epic is, but for us, you just right click in any text box and it's an option in there that you can then do that. And yeah, it allows you to write shorthand, but turn it into a readable note, which is really cool.
It is awesome. It is a great thing. So anything that you're looking at that way can be a good one to do as well, especially as if your system is having open notes as ours does as well, making sure that you're keeping an eye to satisfying coders, but also making the note readable, right, for patients as well. That can be a good one too.
Laura has a question here before we go.
Yes.
Stacy, are you ready? Okay.
Sorry, I couldn't figure it.
That's okay.
I just wanted to comment, Megan, you had mentioned like the needing when you want to pull the data on types of visits. We were able to build visit types into Epic for the visit scheduling, and then that allows that based off of the visit type and the age of the individual, that brings in the right template for us.
Right.
And then it also gives us the data on what type of visits are we having. So I don't know if that's useful for you or not, but wanted to mention that.
Yeah, that's awesome. I love that. And this is why this is so cool, because you get to learn from everybody else as to what they're doing too. So I'm going to make a note of that and look into that to see what we can do. I do think our medical providers have some pieces of that, because that sounds familiar to me. I don't know that our team has jumped on the bandwagon with that, which, the usability of Epic for behavioral health has gotten a lot better than it used to be. So that's the other helpful thing about that too. Laura's asking about using episodes. We have not used episodes. I know other people do, particularly those that are using collaborative care models and COCM workflows have used episodes of care, but we have not done that as well, not at this point. I think there's a lot of benefit to it, so it's worth exploring to see if it fits the needs for your system.
Is anyone using episodes that want to share their experience?
We are.
Tell us more, Stacey.
So every time we start treatment with an individual, there's a button for us that we have to actually create an episode of care before we can do any documenting. So we click that button, and then from there, any visit we have with the patient falls under this clustering within the episode. When you're done, if you know you're done, you can end resolve episode. There's some things that for us, aren't very clean with that. It does allow us to get data on length of stay, if you will, and who's under your care. But if you resolve the episode, we use the treatment plan tab. We have to create treatment plans for ongoing care. If we resolve the episode, it ends that treatment plan. If the patient, something happens, they show back up in a week or 2 weeks or 3 weeks, we have to start all over with the treatment plan. And so we've, as a program, have chosen to not resolve because I just want to make it easy on our staff to just like pick right back up if the patient should need to resume sooner than anticipated. So there's some things to still sort out with that, but
I appreciate that. That's a great idea of not resolving it. I think that makes a lot of sense, to avoid having to delve back into all the treatment plan and all that, which is another really good point that depends on the needs of your system. Again, if you're certified as any other kind of like mental health facility or substance use facility or whatever your organization is, right? You might have different needs in terms of having to create treatment plans and all that documentation too. So it's worth, again, having a compilation of people together in terms of Epic expertise, as well as coding needs, as well as what your system is requiring you to have there to kind of pull it together, while also making it feasible for integrated care. Because again, most of these were not actually created with integrated care necessarily in mind. It's getting a lot better, like I said, so there's more and more pieces that are, but we're still trying to kind of mush our stuff into a medical system documentation world. There's a lot of benefit to it though too. Let's see, other questions that I've missed.
Yeah, it was related more to the episodes. Like there's other Philip did just with pregnancies cases for pregnancies, and then Lara was just commenting maybe it's wise not to use episodes.
Yeah.
I'm struggling to see the benefits. Go ahead, Megan.
No, the only thing I could think of that as Stacey outlined, is that if you're using episodes of care, you're going to be able to pull more stuff in terms of when somebody started, right? And when they kind of quote unquote ended, which Stacey totally called it out, that in integrated care, the end thing is sort of a mushy piece because people are seeing for lifespan care. I think I would be asking a lot of questions to the people that are recommending that you do an episode in terms of what does the workload look like for that? How much work is involved with using them versus just doing a chart note for each visit? And what are they saying that it's going to give you? Those would be the questions that I would be asking. Not having used it myself, I don't know that I can say too much about the differences there. Stacey, I don't know if you have other comments on that from your use of the episodes.
yeah, I like your recommendation that you ask a lot of questions and try to understand it. We in integrated care in Maine have gone towards that because the larger behavioral health system, which is outpatient, uses it, and we were pulled along with their build, if you will. So we do it, but we find ways to make it work for us so that we can still catch some data on who have we enrolled, who are we working with, but then try to reduce barriers for our staff. I don't want to make it more clunky for them. I want to make it as easy as possible. Right.
No, I totally agree. I think that's a great point. And I think that calls out the fact that, again, our programs could be coming into existence and become an offshoot of an already existing behavioral health program that's more outpatient. And so then there's going to be expectations for documentation that may or may not really be necessary for integrated care, which is very much worth just talking out with the people involved. And I would also be looking to what the medical providers in your system are being required to do. If they're not being required to do an episode of care or a treatment plan or those kind of things, then why would behavioral health providers be asked to do that? If there's, again, whatever the local rules are for your system, maybe there is something different, but my guess is there's also going to be some amount of discussion and education that might be helpful for coders to just understand what it is that we're doing as well.
Which that also reminds me again that one of the things to keep being aware of it is that with these creation of notes or smart phrases, it's an ongoing process. So, things change and the necessities of the clinic change. Also, the data do you want to collect? So this is probably a topic that it will involve, to revisit. I will say at least once a year to just make sure that things are on track, refresh. And then maybe also you're doing things that you don't need. And then you realize, well, this is taking time. Maybe we can do things differently. And not just that, there's also upgrades on Epic, right? And you have to adjust to that. And then maybe there are things that they can be useful to make your documentation more easily and, less time consuming or whatever. So this is definitely a topic that continues to be revisited often.
Yeah. Yep, I agree. I completely agree, Martha. And I think the ongoing need to continue to edit and modify the smart phrases is super, and the templates is a super smart thing to do. We have gone back to our coders periodically to be like, do we still need all of these things? Are you sure? Because sometimes that answer changes too, right? And if they're like, no, you don't anymore, then we can throw that out. The template that we use now is quite a bit longer than the one that we used when I first started. But I will also say that there's a lot that I don't have to type in by myself anymore, right? That it's just prompting me to go through. So there's also a certain amount of discussion amongst your team to talk about preferences in terms of how much people want to have in there as cues and prompts and drop downs versus how much they just want to type their own thing and kind of move on with their day. Yeah,
So
Phil, I
I
appreciate
have-
the comment too about episodes for pregnancy. I would agree that I know that that's used in our clinic for OB care, that they're using episodes for that. And we actually don't document within that. We document outside of that episode. And as a part of just regular medical care, that's where all of our documentation lives, which has been easier, I think, for us on that side too.
So Philip was asking, they're going, the medical providers are more shifting to problem-based charting. Any thoughts on how this could look for BHCs?
Problem-based charting. Tell me more about what you mean by that.
So basically what it looks like is almost like the A and the P is listed under each specific diagnosis.
Oh, sure,
and
sure.
so then there's ways to almost automate it. So you're kind of documenting under the diagnoses, and it kind of creates a space where then the next person, whether that's a BHC or another medical provider, gets that really brief information on each specific thing through like the problem list in Epic, rather than ever even needing to go into a note unless they want more info.
So you're talking about putting more into the problem list itself versus putting things in the text of your note?
Yeah, like over my career, like sometimes I might add, if I use like a grief diagnosis, that like mom passed away in, the summer of 2018, but I almost never write in the problem list. And this would mean actually putting some really relevant information in there. So medical providers are seeing, like maybe under depression, that I taught them about mindfulness, and they're working on some value congruent behavior. And like they're reading that from the problem list without even going into like a full, even SOAP note.
Yep. I love this question. Thank you for bringing it up. We've had lots of different conversations about the problem list over the years. I would say, Martha, feel free to chime in as well. I think we've leaned back into, we do some with the problem list, but we've allowed the providers to, since they are the owners of the, we're the consultants to the providers in our system, right? So they're the direct provider for the patients, and we're there kind of as a support. We may throw some things into the problem list, but we're not going to muck around with it a ton, in part because of feedback we had from our provider group that they preferred to kind of maintain some ownership over that section of the chart. It's also not a section in our system, in our clinics, that our providers were using as consistently. They were much more in the habit of using the notes in the most recent visits to have the most up-to-date information, because people had really different habits in terms of how often they were going into the problem list and making edits and updates, and also not wanting to have to document twice for what's going on. So that's where the definite robust conversation with your system. One thing I have seen for our medical providers, though, is that their notes now are looking much more problem-based, just as you outlined, where they're going through each diagnosis and then throwing in their plan for each diagnosis. And I think that makes a ton of sense for the medical world, where they're dealing with so many varied and diffuse things, right? And that's something you can certainly talk about with your team. I personally probably have a bias towards wanting the behavioral health notes to be a little bit more comprehensive, to integrate everything together, to have a more holistic view of the patient. I think that's one of the huge value adds that we're able to add in. And as the note template that Martha had shared shows, our notes in the assessment will talk about their diagnosis, but also in the context of, right, whatever else is going on. So we're going to be keeping in mind not only behavioral health diagnoses, but also medical things that could be going on, systemic and contextual factors, right, that are a part of it. And I think that ability to put things into a whole picture is really helpful for our providers as well. Now, that's not to say that there are not times when I don't separate things out a bit when I'm dealing with a particularly complex or something else more specific going on. Sure, I might do that, but I still want to have a really good holistic view as part of that note. Again, it's worth talking with your system though, your team, your group, you know, to talk about what's really needed for your folks.
Ashley, it's commenting, I would love to know if folks are including the treatment modalities as well as goals, interventions, and objectives. We are standardizing our template now.
Yeah, I'm happy to say a little bit more about that. So I did attend the documentation Palooza, which was great. So we have that, you know, PCBH template. We're also going to use it for our COCM program as well. We have a standard template work group going. You know, of course, it's a bunch of LCSWs and myself, who is also one. And so we have been overthinking, surprise, how to sort of differentiate, right, between all of those things. Like, are modalities actually just interventions? Like, what language are we supposed to use? Do we have to include the interventions and the goal? For like our system for coding, like we do have to include a goal. We have to include, you know, progress towards the goal, and we do have to include an intervention. So I'm just curious from y'all's perspective, because when I look on the template that I got from the documentation Palooza, you know, there is the intervention and there's the plan. And within the plan, there's behavioral recommendations. So just wanted, and then there's like an objective, you know, drop down. So just curious everyone's thoughts and what they currently have.
Yeah, the progress towards goal is something that it was probably been many years now, but that was something our coders wanted us to add in. And our dropdown consists of not applicable, right? If it's a first time visit, or ongoing. And they said that was sufficient. And we were like, sweet. So that's all we put in there, because we're going to write it out in more detail anyway in the rest of our note. So we've tried to have our required things be as simple as possible, to try to make it as straightforward as we can. You're right to talk to your team in terms of a shared understanding, right, about what these drop downs are. Like for the interventions, is this just the modality that you're using? Is it what you're actually doing for your intervention? Like what are you doing? So it's just coming to a working agreement with your group as to how you want that to be defined, would be my suggestion. I don't think it has to be super detailed, because it's an overall guide. Like, this is kind of the lens we were using. This is kind of the stuff we were thinking about. And that's probably going to be sufficient to help move care forward, for folks that are reading it from the outside, you know, to understand it. I don't know if others have other ideas on this though, so feel free amongst the group to jump in.
Kara, I know you were commenting something on the chat, but was this related to Ashley's question? If you can unmute yourself, that will be great.
Which comment?
It said, you never have to document twice as you build in a smart phrase to pull the problem list.
Yeah, we just converted to Epic, and you know, and I've been fascinated with this template build because I'm one of those nerdy people that's a super user. And so but what I finally got is that the way that Epic is arranged is there's the chart, which contains all that information about the patient, and then the note is just documentation, a particular episode or change in the chart. And so as much as possible, we're trying to document in the chart and then use the smart phrases to pull it into the note. So we never have to write things twice, even though I might be jumping around to put the patient goal in the patient goal section, or the assessment and plan in the problem list section. But then I'm just watching the note just pull it in and write it there automatically. So no duplication involved.
Yeah, I love that. I think that's great. And again, love having the super users on the team. It's so helpful and important to have that. So thank you for that. But I agree totally that as much as you can, trying to use the shortcuts, use the tools within Epic so that you're not having to double document anything. And if you're ever finding that you are, that's a great time to ask a question, to be like, is there a way to make this easier so I don't have to type this twice? Because there's a lot more tricks and shortcuts in there than we might think. So that's a good
I even found a way for it to do the math to calculate the number of minutes for the session.
Yes.
That's awesome.
Yeah, we had to start adding that. We had one insurer that decided that they wanted to know the exact start and end time for each of our visits. So we've now had to put that in. We just put it in the text of our note, and we just put it in by hand, because it was only for one insurer, and having it built in for, I don't know, it was just one of those things that you were like, really, one out of, I don't know how many insurers we take at our federally qualified health center, but a lot more than one. So
It's required for all of our insurers, but in the LOS, you can just type now in the beginning and now at the end, and the dot phrase pulls it into the node, and there it is. So
well, that's good. That's helpful that that works for your system, because I think our system has gone to time-based codes, but it doesn't work for the psychotherapy codes. They're not linked up for us very well. So it mucks things up for our system for some reason on the back end. So again, talking to your billing people, your coding compliance people, all of those different pieces to try to get it to line up, I think is helpful. But yes, having the calculators built in, definitely worth a question if that's something you're being required to do, to say, how do we do this, right? To get that built in there too.
So the other thing that it's coming to my mind when we think about, you know, Epic and all the different things that you can do, I see that my nice colleague here and coworker at Daniela, it's here in the line, and I have heard her say different times, particularly when we were ruling out the COCM, that there are different versions of Epic. So Daddy, can you unmute yourself and tell us about that? We're giving these advices, but then it also be that even though we all have Epic, we're dealing with different versions of Epic in our own systems. So can you tell us a little bit more about it?
Yes, definitely. And thank you, Martha, for putting me on the spot so early in the morning. Yes, I think it's important to know or not get frustrated if there's a recommendation that is being made and you want to run back to your team, and it just may be that your particular version of Epic isn't compatible with that. There's, like Martha said earlier, there's upgrades or there's basic versions of Epic, and there's fancier or more encompassing versions of Epic that your organization may have access to. So that's just one important consideration, but I do agree with the comments throughout. I just wanted to emphasize here with my work is that you want to count the clicks. It might sound silly, but all the clicks add up over time, especially when seeing so many patients throughout the course of the day. You want to count the clicks and emphasize the number of clicks to your tech team or your billing team to automate or drop down or smart phrase as much as possible, because all that will add up over the course of time and lead to burnout, lead to frustration. And that's essentially, we want to keep our teams happy, right? To provide great care. So just wanted to make that footnote. I was starting to type out the whole episodes thing in chat, but it was too long. I did want to mention, I've had different experiences in Epic. I worked with an organization out in Washington with particularly collaborative care, where we were using an episode of care on a monthly basis. We were opening it at the beginning of the calendar month and closing it at the end of the calendar month. It was directly related to the collaborative care billing structure. So that's how we were using an episode of care. With another organization down in Santa Cruz in California with collaborative care, we were using the episode of care for the entire duration of their episode of collaborative care, however many months that was. And that was just to show that they were active and would help with the registry built that is required for collaborative care. So just wanted to throw that out there.
So I think at the end of the day, it's just being very, like, you know, our integrated care models force us to be very flexible, right? And we adjust to different things that you can do. And I think these type of conversations help, because you can hear what others are doing that maybe you didn't think it will be helpful. And that will bring you an idea of, oh, maybe this is something I can bring to my team. But like we have been, you know, reinforcing, it's important that you include in those conversations different people of your team to take the best approach for your own side or your need. At the end of the day, with the goal of making life easier for everyone. So thank you, Danny, for that.
Yeah, this is great. I think, Tara, the smart phrase, I just had a question. Ashley asked about the smart, it's just .now, is that right, for getting the time in?
Whenever there's a time, if you just type in, it'll just timestamp it And
Nice.
so if I remember to do it at the beginning and I remember to do it at the end, it calculates. But
Yes.
otherwise, it's just easier because
That's cool. I'm gonna try that. I'm excited to try that one out. I think that'll be good.
I
One of
think
the
under LOS, you might have to open up or expand the part that asks for the time. But for ours, it won't even let us close the note unless we have a time in there. So, which I hate, but it's required.
It is what it is, right? Even little things like today's date dot TD will give you the today's date. It'll just throw it in there, which for me personally was like amazing because I don't know how many times I check the date on a daily basis to try to remember what the date is. So that was a nice one to just be able to throw into.
The other thing that I think was really helpful, our Ocean is how we're doing Epic, and they had a lot of trainings and videos that come with it. And one of them was really talking about note bloat. And so basically, it reassured you that legally anything that's in the chart doesn't have to be in the note. In other words, you don't have to duplicate, like you don't have to print out the problem list or print out the
right.
medications because you can access it through the notes. So it's there. So today's date or who did the, who's doing the visit, that's already in there. So that's nice.
Yep. No, I love that. I think that's a great reminder. And that OCHN versus not OCHN also could be part of the difference between the .now part for us as well. So I'm going to explore that. I'm very curious about that. I think that'll be good. Other questions or comments that people have in terms of things that they're wondering about or things that they've already been using, tried out and want to share? Not yet. Okay. I think one of the other, yeah, go ahead, Sarah.
I was just saying that another thing that we're doing is when we do the contextual interview, putting that information in the social history paragraph. And so again, it's going directly into social history, which our medical providers will often write in or access as well. And then you pull it into the note, and that gives you that context. And then then if you go back, you can update it, like, you're still living with your grandmother or whatever it is. You can keep that current, and then everybody can have access to it.
Mm-hmm. That's a great reminder too, because I think in our system, they have a social determinants of health section in our version of Epic that is in there. And that's one that we've had conversations about whether are we going to document in there? Are we not going to document? Like who's using it? How are we using it? Who's responsible for it? Who's updating it? So things like that, as new tools become available in your system, it's good to have a conversation not only with your own behavioral health team, but with the medical team at large, just to talk about, again, ownership of those sections and who's using them and how, as a way to kind of share it across systems. We actually have some folks that do some initial screening for social determinants of health now in our patient services team. So they actually are in that even more than we are. But it's great because it gets it started and they get things set in there, and then they're able to send patients to the right place once they actually arrive in clinic. So again, lots of different ways for these tools to be used, and talking with your whole system can be helpful to make sure that you understand who's using what and why. I do periodically have just sidebar conversations with providers too, to be like, what do you actually look at in the notes, right? What's actually helpful? Especially as our notes, I feel like, have gotten somewhat longer over the years. And again, partly due to requirements from coding, but partly just due to stylistic changes of writers on the team. They're not outrageously long by any stretch of the imagination, but it's just different. And so checking in periodically with your medical providers to just see what's helpful in the documentation. What do they like? Is there anything they want to see more of? Is there anything that they don't care about and could see less of? Those kind of things can be helpful as well, just to make sure you're meeting the needs of your providers.
So we have a question here from Laura about the screening tools. So we have like Mocha built-in or MMSE, and we don't use Mocha, but we have some tools that we can pull down, right, Megan?
Yep. We have the I'm blanking on the one, the St. Louis one for mental status.
Slums.
Thank you. A really good sign that I can't remember the name of it. So that's great. It's all in there. It's built in. It's within a separate tab for, I think it's under mental health activities. It's an activities tab, and it's got all the questions in there and all the items. And I often still print out my own because I'm old fashioned, and also they can write on it for the writing parts. But it's nice because you can go through everything and the scoring happens automatically. You're just clicking, did they get it right or wrong? And the scoring all happens. But that's also one where we have then created the ability to blow the score into our note. With that, those in particular with the mental status ones, we also created a explanation smart phrase. We've actually done that for most of the screeners that we've used to try to make it easier for providers to understand what these screeners mean. We were having some people misunderstanding what they mean initially, like, oh, you've screened them and this means they have dementia. Like, nope, not what a screener for mental status is going to say, right? That's not what we're doing. Or they did the kids did a Vanderbilt and it was quote unquote positive, and so they have ADHD and that's all I need to know. We'd like a little bit more information, right, than just this screener. So having a little blurb in there to kind of explain that these are screeners and this is the extent of the information that you can get from it, right, can be really helpful. We've always explained it in our assessments, so it's in there, but having it in there under where the measures go can be really helpful for people to understand, oh, they got a 10 on the PHQ-9. What does that even mean, right? So then you can have a little scoring key under it just to give a quick cue as to what it means. And again, not to make your note overly long, but just to make it useful. And again, knowing that patients are reading this too, it makes it easier for them to understand, right, what's going on. So you're using patient-friendly language and strengths-based language to help understand the meaning of these things too.
Ashley mentioned that they do the same with the PHQ-9 GAD-7 as
Yeah.
we do also here, Megan. And one of
Yep.
my favorite things is that when we blow it out, we can see the dates of the administration. So we
Yes.
can see if they're actually improving or declining or
Yep.
whatever. So I like that even you can, so the dates will pop up.
Mm-hmm.
Very
Yeah, we had
beautifully.
our Epic people create a smart phrase to drop it in for not only today's administration, but the last 3 administrations. So you can see it to compare it right away. And that's something that you can easily modify how many you want to have included. Yes, Phil.
I don't know how this worked, but when we originally built our template, there was also a way that we got help. There's kind of 2 different codes that will allow you to collapse sections. And I'm sure that can be built with any type of header and any type of thing too. So some of that stuff that has just more text, sometimes it is nice to find like a formatting way to collapse it down to like, here's what the provider needs to read. But if you want to look at like every individual question, click to expand kind of options can be really nice too.
Yeah, that's a great point. I love that. And you're right, because there's times when you're doing much more detailed whatever, and you don't necessarily want all of that to be hanging out there at first glance. It's a nice feature.
I think, yeah, I was looking if we had missed any comments or questions, but it looks we're covering here already. So we actually are 7 minutes away. We want to be respectful of the time, but so this is the time. If you have any questions, comments, please unmute yourself or write it on the chat.
Sorry, Martha, I'm just going to jump back real quick to a question
Yeah.
that I was talking here about the slums from Laura. I got behind in the chat questions. So the
Oh, yeah.
slums was a measure that we did start using before we had realized that it was an Epic. We had somebody in our team that did a little bit of research to see what screeners might be better at pulling out more mild cognitive impairment. And that was the one that at that point that they found data for. This was many years ago, so maybe there's something else better now. But it's a really good point that sometimes you may end up making decisions about what screeners to use based on what's already built into Epic. You can petition your local Epic people to add questionnaires that you want to have added. It is at least for me and my system, it was a fairly long, laborious, and mildly, if not fairly painful process just because it took so long. So being very thoughtful about those requests is helpful. And if there is something that's already in there that you can use and it's workable, it's certainly going to make your life easier to just use what's already there. That's not to say that you shouldn't be asking for better measures if there's better measures out there that should be added in. It just may take a minute for that to happen. We had added things in for substance use screening, and it took like a year and a half, I think, if not longer, to get them added in. So every system is going to be different though, in terms of how much control you have over that. So again, it's worth talking to your people to see how it works.
That's helpful. It's frustrating because I'm a neuropsychologist by training, and I prefer the MoCA significantly over the slums due to the psychometrics. And so we use the MoCA in my system. But it's like, okay, so now I kind of feel like we're the cart driving the horse, like the tool that's supposed to help us. We're having to just acquiesce to whatever they have. But I did just go through a meeting with them this morning for 2 hours where they basically put up on the screen the things I could use. And then all the things that were on my list that we already use that like we have to petition and junk for. And so, you know, I had the same thought, like, is this worth all the battles?
Yep.
Or do I just need to find something that gets at the general gist? So that's why I was curious how y'all approached it.
Yeah, it's, you know, with all these systems, there's some benefits and some limitations, right, that we're going to have coming into it. I would say if you choose to wait and not petition for now, set some kind of reminder yourself to come back to this in a year or 2 years to check again. Because the stuff in Epic, there were some things that weren't in Epic when I first started that then they were there now, you know, PTSD screeners and things like that. The PCL5 is in there now. It did not used to be in there and it is now. So there's things that's worth just continuing to bring the question up to your Epic people periodically, just to kind of see, have they had pressure from other places that's elevating this to make this a thing that they're going to be more likely to work on. And I always try to approach with curiosity of like, tell me how this would work, because this is what I really want to use. So how does this happen? And just having an explanation of what that means in your system, I think could be helpful. But that is it's an important thing to just know for your system how it works.
Wonderful. Thank you.
Yeah.
Well, I just want to also highlight that this conversation, it was not just to share information, but also networking. Like if you saw people commenting, I know, for example, from the episodes that we talk and you are using it and you saw someone comment about it, this is also an opportunity to network and get that name and email and continue communicating offline with people that were joining here. So we have 3 more minutes. Anyone that is wanting to share anything before we leave?
I just have a question. Will we do these again at all? Like in a month or two? I mean, my system, literally, we're starting this journey. Launch is October 24. So we have a year, but like I'm still in like 10 hours a week of Epic meetings. I want to gouge out my eyes. So I feel like I'm going to just continue having questions that I would love to like bounce things off of folks.
Yeah, that's a very good question, Laura. We don't have anything on the books, but I'll bring that to the team and we'll definitely have it marketing and goggle in our list if this is something that people are interested that we can have.
Yeah,
I don't know if other systems are doing this, but it's super overwhelming. And of course, the Epic people are like, this is what you need. And I'm like, I don't think that works for integrated care. And so they're just really pushy. And so having people who actually are using the system, doing the same kind of work that we're doing, I think is super valuable.
Yeah, no, I think it's a great idea. And I love that idea. I think it's great that Martha's going to take it back to the team and kind of see what's going to progress. I also would highly recommend that you talk to your Epic people and say, hey, can I tell you what I do to explain what I do so that you understand
I've tried.
Yeah. And then maybe offer again and do it again. And you know what I mean?
I
get it. I get it. Because when I started there wasn't anybody doing integrated care in our system when we started. So helping people to understand that we needed to be able to schedule patients and chart was like, what? You want to do what? Like that took them, it still is something that every time I have a new person in my system, there's always something missing in their security, but that's fine. We can work it through and get there. And just
my Epic rep said, well, I worked as a tech on an inpatient unit once, so I know what you do. And I was like, no. But she says it every time we meet. I know. I'm like, no,
still no. Yeah. I'm sorry. I feel your pain and I totally get that. I'm glad that you came today. So hopefully you can get some support from others here.
I wrote down a bunch of names.
Good.
So if I stalk you, it's because I'm lost and drowning. That's what's going on.
Okay, so just, we're close to an end here, but Christina's mentioned, does anyone have a good integrated care 101 that is effective for Epic?
Just in terms of a spiel to tell people about?
Exactly.
Yeah. Yeah, I mean, that's definitely something to work on for your team. I think that I have developed my own explanation over the years. And I actually start with what I say to patients, to be honest, when I'm talking to the Epic people, because they often have so many potential preconceived notions, right? As Laura just outlined, in terms of what it means to be doing integrated care. That I think that would be helpful. I agree, Tara, that they need to hire BHPs to help them with the
Absolutely.
integration. Completely agree. They're right down the street from us, Martha. So maybe we should give them a ring and let them know this is what they need to do.
Right, exactly.
Stop by.
Yeah. It's apparently a very cool campus. So maybe we'll just go
That's what
take a
that's
tour
what
and
I've
then happen
heard.
to mention what they need.
Absolutely.
Yeah.
Well, thank you everyone for joining us. Thank you so much, Megan, for leading this conversation. Thank you for all the valuable nuggets, all the conversation and participation. This is going to be recorded. If you need it, you'll gonna be listening to it later. Thank you for joining, and to be determined, I'll follow up to see if this conversation will continue. So have
Thank
a
you,
great
and thank
week,
you.
everyone.
Thank you, Martha, and to CFHA for doing this conversation. We appreciate it.
Bye, everyone.
Take care.